Video number 7 is about VV ECMO. We'll go over some basics first. The indications are severe ARDS, refractory to lung protective ventilation strategies, and PGD after lung transplant. So how VV ECMO is set up is that there's an inflow and an outflow cannula. The inflow cannula drains blood from one of the central veins of the body, goes into the ECMO machine, which is a pump followed by an oxygenator, and it goes through an outflow cannula into the same or a different central vein. You might notice that the cannulas are named relative to the ECMO circuit, not to the human body, and we will see in just a minute that the outflow cannula has to be closest to the right atrium, and the pump is before the oxygenator because it is easier to control the rate of flow that way. We'll talk about the configurations next. So here are my beautiful drawings. And so the first one that we'll talk about is right IJ fem. So the inflow cannula is in the IVC. It drains into the ECMO machine, and the outflow cannula then deposits its blood into the right IJ next to the right atrium. And the pro of this configuration is that you will get the highest flow. The con, though, is that this right IJ cannula tends to migrate out over time. I've seen at least one accidental decannulation. So it's generally really good for if you need high flow temporarily, but there's usually the next two configurations are better. So we'll talk about fem next, and this is a case where the drainage or inflow cannula is in the IVC, goes to the ECMO machine, and then the outflow cannula is also in the IVC, but it is closer to the heart. And this is I think where you can see best why the outflow cannula has to be closest to the heart, and that's because if the inflow cannula was closer to the heart, you'd have a lot of recirculation of blood, right? As it doesn't make sense that the oxygenated blood is going to pass next to the IVC or pass next to the inflow cannula before the heart. So the pro of this configuration is that you can cannulate patients the fastest, especially during emergency situations. You also get very high flow rates, not as high as the right IJ fem configuration, but pretty close. And but the con of this is that it's going to be difficult to ambulate patients, so it's really not a good long-term strategy. I think it's good for up to a week, but then you kind of have to think of, all right, where's the patient going? And then for long-term strategies, you're going to switch to this dual lumen strategy. And the two trade names for the dual lumen cannulas are Crescent and Avalon. And what this is you have a single cannula in the patient that has kind of two channels. So you can do ECMO with only one cannulation site. This can be done through either the right IJ, or I've also seen it done subclavian, especially for the lung transplant and the COVID patients who are sometimes on VV ECMO for weeks or months at a time. And the drainage cannula is a like dual stage drainage or inflow cannula, drains into the ECMO machine, and the outflow cannula is adjusted in a cath lab to shoot directly at the tricuspid valve. And so the pro of this, like I was saying before, is it has the best ambulation. Patients, we had COVID VV ECMO patients walking around with the subclavian crescents. However, the con of this is because the cannulas are smaller, you're going to get the lowest flow. So this can only flow at I think kind of the max is about 3 to 3.5 liters a minute, whereas the fem in the right, IJ you can get closer to 5. And then we'll kind of talk about, like, as an overall concept, all of these configurations, all that they truly are, is it is like having an artificial lung inside of the central venous system. So I also have a diagram here. This is just how I think of it. You don't have to think of it this way. But one of the key concepts here is that if you want to shunt more blood to the ECMO circuit, you're going to increase the RPMs of the circuit and try to decrease the cardiac output, usually through beta blockers. And if you want to shunt blood towards the lungs, you want to decrease the ECMO flow and increase the patient's cardiac output. So we're going to talk about settings next, but just keep in mind, think of it as ECMO is like a parallel lung inside of the central venous system, and you can control how much or how little blood goes to that by increasing the speed of the ECMO pump or increasing or decreasing the heart rate of the patient. We'll talk about settings next. So settings wise, let me get this situated, there we go. So settings wise, RPM is essentially how you control the pump flow. So generally they go between about 1,000 and 4,000 RPMs, and it is you can get up to about 5 liters of flow. So the higher the RPM, the higher the flow, and it's kind of like the cardiac output of the circuit. Sweep is the rate of gas flow through the oxygenator. So as blood flows through the oxygenator, gas is pumped next to it, and then O2 and CO2 are passively exchanged across the circuit, or across the oxygenator, excuse me. And so the faster the rate of sweep gas, the more CO2 is going to be exchanged. So the rate of the sweep gas is kind of like the minute ventilation, is that the higher the rate of the sweep gas, the more CO2 can be exchanged. So the higher the sweep that you need, the less the lungs are working. And that's kind of a good way to look at it, is that when you wean VV ECMO, you wean the sweep down first and see if the lungs can eliminate CO2. And FDO2 is the concentration of the O2 in the sweep gas, kind of like the FiO2. This generally is less of an issue because oxygen diffuses so much faster. You generally in the rate of oxygenation is also proportional to the flow. So the two main settings that you have to know are RPM and sweep. FDO2 is less of a factor. All right, let's talk about some complications next. We'll do medical complications first. And first and these are all related to the systemic inflammatory response caused by blood circuit interactions. We'll first talk about vasoplegia briefly. And we've already talked about this in multiple other talks, but patients who are on chronic VV ECMO have chronic mild vasoplegic shock, and it's treated with a volume resuscitation and a low-dose vasopressors. The other two things that other two medical things that you can have are bleeding and thrombosis. We're going to talk about bleeding first. Just as a aside, that ECMO circuits cause both bleeding and thrombosis sometimes at the same time. We tend to focus more on the thrombosis because that's what it causes more damage to the patient. We can always give somebody more blood, but if they have a blood clot in their brain or a giant blood clot in their lungs, that's a lot more difficult to fix. So we generally allow patients to bleed more rather than have them thrombose and throw emboli. That's why patients on ECMO are almost always anticoagulated. So there's a bunch of different etiologies and physiologies behind this. I'm not going to go into this. It's beyond the scope of this talk. And I put some labs here that you can order to see if the patient is bleeding. CT heads are very helpful, especially if they have a change in neurostatus. And the treatment of this is just to pause the anticoagulation and then try to correct coagulopathy as you can. Surgical intervention is generally not useful here. And then we'll talk about thrombosis briefly. The etiology is the same. The patient's thrombosis in the patient is generally not seen as much here because the lungs and the oxygenator act as a filter that catches clots before they move to the arterial side of the body. So usually in VV ECMO, you see a lot more circuit thrombosis, whereas VA, which we'll talk about next, you see a lot more patient thrombosis. And then again, the way to treat this is to anticoagulate the patient or do a circuit exchange if the circuit, especially the oxygenator, has a lot of clots in it. And we'll quickly talk about circuit complications to finish up. These are related to the cannula as a pump and the membrane oxygenator. The first one we'll talk about is hemolysis. So this is due to shear stress on red blood cells as they move through the circuit. So things that will increase shear stress, higher RPMs, smaller cannula size, and then cannula position. So if it's next to a wall or in some kind of or the position creates some type of weird flow that can happen. We're going to talk about this more in the LVAD lecture later. Just know that the LDH, plasma-free hemoglobin, and pink urine can help identify it, and the treatment is to either to transfuse a patient and then fix the cannula problem, and you can do this by either decreasing the RPMs or by adding additional cannulas to do VVV or VVVV ECMO. Extra cannulas help because if you have more, or if you have if the total flow of the circuit is going through a greater area, you can have less speed. So this is just an application of Bernoulli's principle. How VVV and VVVV ECMO is done is out of scope here. We can talk about that more in a different lecture. The next issue that we encounter is chattering, and what chattering is it's the inflow cannula vibrating as the central venous system collapses around it. So essentially, a patient gets a volume down, and you can tell when you see the inflow cannula chattering, and literally moving back and forth. And then treatment for this is just to give volume resuscitation and to hold diuretics, obviously. You can also decrease the RPMs if it's clinically appropriate. Then lastly, we'll briefly talk about recirculation. We already kind of talked about why the outflow cannula has to be closer to the right atrium. In recirculation, blood moves from the outflow to the inflow cannula without going through the patient's heart and lungs first. And how you diagnose this is their SAT will oftentimes decrease, and if you sample blood before and after the oxygenator, they'll both be very high, within the 400 to 500 millimeter of mercury range, and that kind of tells that you have some recirculation. The way to treat this is to reposition the cannulas. So generally, depending on who you ask, you want them at least 10 to 15 centimeters apart. You can also add extra cannulas. And again, that's out of scope of this talk, but just know that you can, by adding extra cannulas, you're going to decrease the amount that the cannulas interact, and then you will decrease recirculation that way. And we'll talk about VA ECMO next.